Hello and welcome to session 28 on the abdominal organs. Clinical anatomy of the esophagus is going to be something that you'll want to be familiar with because of the herniations that occur through the esophagus or from the esophagus. There's a couple different types. There's a hiatal hernia, which will be a protrusion of the stomach into the mediastinum through the esophageal hiatus. And then there's sliding hiatal hernias, which will be abdominal esophagus and cardia being distended. And that will be a portion of the fundus that will enter the thorax with regurgitation and/or associated pain. The paraesophageal hiatal hernias are less common, and this is where the cardia of the stomach remains in place and the fundus will slide through. A Barrett's esophagus is a squamo-columnar junction proximally removed from the esophagastric junction rather than coinciding with it. This will be something you'll discuss more in pathology. Then you can have esophageal varices, and these will be clinically important and very testable for the USMLE. There is a reverse flow point through the inferior esophageal veins and what we've discussed earlier with the azygous system. And what can happen is if there's a blockage in the portal system or in the systemic venous system, these can get dilated, and they dilate towards the internal surface of the esophagus themselves. This is not good because anything that you eat that could tear these esophageal varices open could cause bleeding and even death from the blood that will then drain into the GI tract. Let's look at the bleeding ulcers, or the peptic ulcers. Now there's a couple different kinds of ulcerations. You have gastric ulcers, which are sometimes called peptic, and there's also duodenal ulcers. What you can see here is you have a visibly pumping vessel that's seen in the bed of an ulcer, and there's a greater than 50% chance of rebleeding after an endoscopic control of this vessel, which is particularly true of the gastroduodenal artery, which is in the duodenal components, part 1. You can also see a pitting with this duodenal ulcer that can be eroded away by the submucosal vessels of the duodenal wall. The base of these ulcers is characteristically white due to the fibrinous exudate and the collagen of the wall. So what are things that you want to watch for with ulcers? Well, somebody will report lightheadedness, a sign of low cardiac output secondary to the hypovolemia that can occur. They will have sticky and stinky stools, say that 5 times fast, and they will not see the non-bloody black stools. They oftentimes have a history of NSAIDs, long-term use, which can give rise to gastritis or precipitate the bleeding from ulcers, or they'll have postural hypotension, which is going to give them a greater than 10 millimeter fall in their blood pressure when they are in the erect position versus laying back. There are different types of peptic ulcers. In the stomach, they're called gastric ulcers. In the duodenum, they're called duodenal ulcers. And in the esophagus, they're called esophageal ulcers. Gastric ulcers, which are less frequent than the duodenal ulcers, are usually from the pyloric antrum regions of the stomach. They're oftentimes linked to aspirin or NSAID use, smoking, and an infection of the Helicobacter pylori bacteria. The gastric ulcers have a much higher mortality rate than the duodenal ulcers, though, because they can erode through the posterior wall of the stomach into the lesser sac, and they can deteriorate or hemorrhage the splenic artery, and a person can actually exsanguinate from that. They were at one point thought to be excess acid related, but now they know that Helicobacter pylori is the result of most of these. Of course, there is a side effect of this through extra acidic mitigation. When we look at the foregut organs, this relationship here is an important portion. Here you can see the duodenum with its 4 different components. The portion that's the first part, the second part, which runs in the vertical plane, the third portion, which runs under the superior mesenteric vein and artery, and then the fourth part, which sweeps up again and connects to the jejunum. Most of the duodenal ulcers are in the posterior wall of the first part and can irritate through and cause a perforation of the gastroduodenal artery. Ulceration of the liver or even gallbladder are possible because of the erosions. Duodenum itself means 12 fingers wide, and it extends as a 12-finger wide C-shaped tube from the pylorus to the jejunum. And in the head of, or in the midst of that C, is the head of the pancreas. And here's a few different things about the portions of the first, second, third, and fourth parts of the duodenum. The most important thing is in the second part, because this is where the hepatopancreatic ampulla empties the bile and the main pancreatic ducts at the major duodenal papilla. This can actually be an access site, so that if there's a removal of a stone, even in the gallbladder or the ampulla itself, that needs to be done, this can be performed by passing an endoscopic tube down through the esophagus into the stomach and actually entering through the duodenal papilla. The accessory pancreatic duct may have a minor opening just above the major pancreatic duct into the duodenal papilla. This is not always the case, though. One thing about the fourth part is this little ligament of Treitz, which is a smooth muscle component of a suspensory ligament, which would be a peritoneum, that connects to the junction between the fourth portion and the small bowel's jejunum. If there is a need to keep foods in the duodenum longer, this thing can contract, making a little bit tighter turn for the food to leave the duodenum and give a little extra time for pancreatic enzymes and bile salts to break down those food products. As we move into the liver, there's several different ways of studying the liver. First is the anatomic lobes, which you should be familiar with because of the imaging needs that you'll have with that. And their lobes are separated by the falciform ligament. So there's a larger right lobe and a smaller left lobe, and two other lobes that will be separated by the IVC in the gallbladder and the ligamentum venosum and the round ligament of the liver. That would be one of the embryonic remnant shunts that we've already discussed. So the four lobes are listed there, and you can see that functionally or physiologically it can be divided up into 8 functional segments and can be transplanted into multiple people because of this. It runs very similar to what a bronchopulmonary segment would do in that it has an independent blood supply, biliary tree, and venous supply that can be segmented away, tied off, and then implanted. The surfaces of the liver, and the anterior surface, it should come just to the edge of the costal margin. With hepatomegaly, it will oftentimes protrude below the costal margin. It's anchored to the diaphragm via the bare area, which is good because if it wasn't, every time we stood up, it would fall onto our bladder. And then we can see that the diaphragmatic surface is going to have the triangular ligaments out towards the edges on the lateral and medial sides. And then it's going to have the falciform ligament with the round ligament of the liver, or ligamentum teres hepatis, which is the remnant of the umbilical vein. The IVC is posterior towards the caudal lobe, and the gallbladder sticks out anteriorly towards the quadrate lobe. The porta hepatis is the largest of the trifecta or portal triad, which consists of a hepatic artery, biliary tree, and portal vein. Portal means to have 2 venous or arterial systems without an interposed capillary bed. And this is exactly what happens with the liver. There is a portal vein that will collect blood from the GI tract and branch into smaller and smaller branches until it gets down to the level of hepatocytes in the central veins. From the central veins, those become hepatic veins, and they will recollect the blood and get bigger and bigger until they become the large hepatic veins, which will then form the vena cava towards the posterior superior aspect of the liver as it passes through the diaphragm and into the right heart chambers. So the liver itself will act as a filter, and it will filter the venous blood that's bringing in nutrients as well as pathogens from the digestion tract. If you have a 55-year-old male who is an alcoholic cirrhosis liver, and he's brought into the emergency department because he's been vomiting blood for 2 hours. He's had a 2-month history of abdominal distension, dilated veins over the anterior abdominal wall, and internal hemorrhoids. Which of the following veins are directly connected to the branches that are likely to be feeding blood to the area of the hematemesis? In this one, you should be thinking of the left gastric veins. And in general, the signs and symptoms that this man is presenting with is classic of a cirrhotic liver with portal hypertension and esophageal varices. Remember, it's the left gastric veins that will drain the esophagus on the abdominal side, and it's the esophageal veins that will drain the esophagus back to the azygous system on the thoracic side. Here we can see a cirrhotic liver. And cirrhosis of the liver is really a fibrous replacement of the hepatocytes because of toxicity and destructive diseases. Alcoholism, of course, is only one cause of cirrhosis of the liver. Once the liver's fibrous replacement occurs, the hepatic blood vessels will be impeded because of the constriction, and that will lead to portal hypertension. The portal hypertension will lead downstream to variceals and ascites, or swelling of the abdominal cavity. Up to 90% of patients with cirrhosis will develop esophageal varices. But bleeding will occur only in about 30% of these patients. They used to do an attachment or an anastomotic portocaval shunt to reduce portal hypertension. Now they're starting to do TIPS procedures, which is a transjugular intrahepatic portosystemic shunt. The TIPS procedure will allow them to connect the portal vein to one of the hepatic veins right within the substance of the liver, and it can all be done under endoscopic surgical procedures. Also, there's an opportunity for liver transplantation if the liver shuts down so much that it's no longer functional. Hypertension is defined as being pressures greater than 12 millimeters of mercury, where normal is 5 to 10 millimeters of mercury. Be aware of this so that if you see some of these pressures in the stems of questions and they don't provide this as a normal function, which they should, be aware that over 12 is going to be hypertensive. Here you can see a diagram showing the portocaval anastomoses that exist, and there are 4 of them. The first is the esophageals, and that's clinically the most relevant of the two, but not always the easiest to recognize. So you have to pick up on the esophageal varices and assume them when you see other dilations, such as the paraumbilical dilations and the hemorrhoidal dilations, which will occur between the superior and inferior rectal branches that anastomose. The ones that you can't see as well as the esophageal would be the ones that are along the paracolic sides, where those body wall segmentals will be picking up some of the branches off of the ascending and descending colon since they've been strapped down to the body wall. The lower esophageal varices are going to be the important ones, and this is just discussing some of the connections between these. In hypertensive varices, including the esophageal seen here, it results when the submucosal veins of the esophagus will become dilated. They get very easily eroded, especially if somebody's got gastric reflux, and it can lead to huge gastrointestinal hemorrhage and potentially death. On the anterior abdominal wall, they'll show up as a caput medusa. which is a distended engorged para-umbilical veins that will radiate out from the umbilicus looking like the Greek mythology creature Medusa. And of course hemorrhoids, which are not all caused from hypertensive varices, but one cause of them is going to dilate the vessels at the junction of the rectum and the anus. Now let's move on to the gallbladder and the biliary tree. Here we can see the gallbladder with its neck, body, and fundus, and a spirally organized cystic duct which will lead it back to the main production of the biliary tree that comes from the liver. Those will come out of the liver via the hepatic ducts, which will then come together as a common hepatic duct. After the cystic duct joins together, it's known as the bile duct, or sometimes the common bile duct. It will then pass into the head of the pancreas and head towards the second part of the duodenum on the medial wall. In that area, it will dilate as the hepatopancreatic ampulla of Vater, and joining it will be the main pancreatic duct. These two substances from the bile salts and bilirubin of the gallbladder to the enzymes associated with the pancreas will then be dumped into the second part of the duodenum based on demand. There are often sites of blockage for gallstones which are going to be typical. These will be secretions, or basically rock candy versions of the substances that are in the gallbladder, which will be two different main types of gallstones. One type is going to be from the cholesterol stones, which is the most common type, making up 80% of them, and then the pigment stones, which will make up 20%. The cholesterol stones are yellowy green and very hard, whereas the pigmented stones are very dark and made up of the bilirubin. The large stones can form in the bladder or the gallbladder and won't be able to get out of the gallbladder because of the narrow cystic duct. It's the small to medium-sized stones which will create blockages by partially making it through either the cystic duct or the common bile duct before they end up getting stuck at the ampulla. So those are three common sites of blockage that you should be aware of. The key difference to telling these apart when it deals with questions is that the ampulla, hepatopancreatic ampulla, is going to be the narrowest point, and you'll also get an associated pancreatitis when this becomes the site of impaction. And this will cause biliary colic, which will cause pain in the right upper quadrant just under the costal margin as a result of the contractions of the tree as it tries to push through some more bile. The gallbladder is a site of concentration, so the liver will make the bile at a 1x solution and the gallbladder will concentrate it as a 50x solution, which is why that supersaturated solution can sometimes drop out stones. There's going to be an important triangle of surgical interest, which is going to be the cystohepatic triangle of Callot, and it's to be avoided during surgery. So the questions that deal with this cystohepatic triangle of Callot will identify three important things. There will be the biliary ducts, the cystic artery, and the hepatic arteries that will define this space. Here you can see an ultrasound showing a gallstone within the gallbladder. This shows the pancreas with its enzymatic ducts running down the main pancreatic duct into the head to join with the bile duct, and then you can have an accessory pancreatic duct which will either join to that and not dump in, or may dump directly into the second part of the duodenum above the primary opening at the ampulla of Vater. The Unsenet process is the ventral component, and the inferior head is the ventral component, whereas the dorsal pancreatic bud will form the superior head, neck, body, and tail. And here you can see the blood supply to this area, all of which is coming off the celiac artery, which you would expect from our 663 organization that we discussed earlier, because all of these three associated organs and the lower part of the esophagus, stomach, and the first half of the duodenum will indeed be supplied by branches off the celiac. We'll be discussing vascular supply momentarily, but what I want you to notice here is that there is an anastomosis between the celiac trunk and the superior mesenteric around the head of the pancreas, with this posterior and inferior pancreaticoduodenal and posterior and superior pancreaticoduodenal will all anastomose around that head and uncinate process. The splenic artery, as you can see, will trail along the top of the pancreas and is quite tortuous, and then the splenic vein will be behind the pancreas. So the pancreas itself will get supply from the splenic, the gastroduodenal, and the superior mesenteric, which is one reason it's very difficult to remove surgically, because there's so much vascular supply and many dangerous things in that area that it's just been unoperable until recently, when they're now starting to do pancreatic transplants that are looking promising. So what else do we need to know about the pancreas? Well, clinically you can get acute pancreatitis, which can be caused by either pancreatic enzymes escaping from the ductal system or after an obstruction or edema of the hepatopancreatic ampulla of Vater. It oftentimes happens in middle-aged individuals where there's a frequent condition of excessive alcohol or heavy meals. The collection of fluid in the omental bursa from an injured or inflamed pancreas will produce a pancreatitis pseudocyst, and this fluid needs to be drained endoscopically upon surgery. There can be carcinoma, which most often occurs at the head of the pancreas and can obstruct the bile coming from the liver, as well as the pancreatic ducts. Patients will present with jaundice in this case. Pancreatic cancer will typically spread very rapidly, because it's very close to the cisterna chyli, so there's not very many lymph nodes that will need to be filtered through before it dumps back into the thoracic duct and the vascular stream. And it oftentimes is not detected in its early stages because the referred pain of a pancreas that's in stress is very similar to that referred pain we get very comfortable with, that tends to be a digestive pain or an ulcerative pain that people think they've got going on, and they poorly attribute that pain to something other than a pancreatic cancer. What kinds of signs and symptoms appear? They may include upper abdominal pain that radiates towards the back, yellowing of the skin and eyes from jaundice, loss of appetite, weight loss, and depression. So you can see that some of these symptoms are not so forthright that you would never miss it. And of course, somebody famous that has recently died from pancreatic cancer, Patrick Swayze, and here you can see a pancreatic cancer underneath that of the head of the pancreas. In fact, the 5-year survival rate still for pancreatic cancer is 0 almost, and Patrick actually lived close to 6 years, I believe. An embryonic component that can affect the pancreas is known as annular pancreas. This occurs when there is a bifid ventral process on the pancreatic bud, which can fuse or touch edges together, and that can strangulate around the duodenum. Early signs of this will be similar to the atresias that we talked about with the development of the duodenum. So there'll be polyhydramnios because the fluid can't be swallowed, and there can be an inflammation of the duodenum as well as the stomach. Here you can see a dye contrast study of an adult that has annular pancreas surrounding that opaque region from the dye contrast, and then this has been a stenosis as opposed to an atresia. So let's finish up with a little bit more about gallstones and pancreatitis. The pancreatitis will cause sharp burning in the epigastric areas after meals, and sometimes can be confused with the duodenal ulcer, which will typically develop in the first part of the duodenum. That tenderness is the most common physical sign that they'll see. With an ulcer on the posterior wall, it may erode to the gastroduodenal artery, causing severe hemorrhage, or it may permit the contents of the bowel to get into the cavity and cause a generalized peritonitis, which can indeed be deadly. The gallstones, which will block the common opening, will create reflux into the pancreas, and that will produce the pain associated with it. Remember, these enzymes are designed to break down proteins, which is what the ducts are, so once they're exposed to it for too long, they will break down and erode. The duodenal flexure marks the transition point between the upper and lower GI tracts, and when you have an upper GI tract bleed, you expect to see dark, tarry, and sticky stools, which have a very bad odor, whereas the stools from a lower GI bleed will contain more of a red blood. As we move into the spleen, you can see that the spleen is one of our largest immune organs, and it's associated with lots of trauma problems. It's one of the most often traumatized organs of the abdomen, and that's because of some of its mobility as well. It has a relationship lateral to the curvature of the stomach, the greater curvature, and sits just superior above the left colic flexure and anterior to the kidney. In a splenectomy, you have to avoid the massive bleeding that can occur from that large splenic artery, which you can see in this angiogram. One sign that you'll see as a result of the spleen shutting down can be splenomegaly, and it's also susceptible to injury or splenectomy that can occur. When that happens, you have to be careful not to cut those very big vascular structures supplying it, which can be seen in the angiogram to the side. The destruction of the spleen will oftentimes cause splenic anemia, where either granulocytic leukemia or some other structure is destroying blood cells faster than the spleen can recycle them. Here is a laparoscopic view of a splenectomy, and this will be indicated for splenomegaly, in which the spleen gets greater than 12 centimeters, and that can occur from liver failure because the spleen starts to take over the components that the liver does. The trauma of the splenic or arterial hemorrhage from the spleen is a result of high-impact injuries and car accidents. There can be any number of blood diseases such as spherocytosis, thalassemia major, and ITP, where the platelets are destroyed, or even Hodgkin's disease. And in the bottom, you can see a splenic laceration as a result of an automobile accident. Another portion of the bowel that's affected by both developmental and pathologic problems is the ileal diverticulum, or known as Meckel's diverticulum. It's a remnant which is not always present, and most are asymptomatic. Typically, if it is going to become asymptomatic, like the one seen in the superior picture where it's been inflamed and is reddened because of its diverticulitis that's set in, the presenting symptoms will be at the age of 2 or younger, and they oftentimes will produce painless rectal bleeding, or they may produce severe abdominal GI pain, which will happen with bloating and that fullness of the stomach. They can also cause intestinal obstruction or volvulus and intussusception, which would cause the telescoping of the bowel. Those are much less common, though. But occasionally a Meckel's diverticulitis will present with all of the features of an acute appendicitis, which is what its major component of a differential will be when you're trying to decide between the two. The symptoms are so painful in some of these diverticulitis from a Meckel's diverticulum that it will oftentimes cause sleepless nights and extreme pain in the abdominal region, and that's very rare in appendicitis. One way that they think of the Meckel's diverticulum is that they have a 222, which is they occur in 2% of the population. They're 2 feet from the cecum, and they tend to be about 2 inches long. Here you can see an unaffected diverticulum in the inferior picture. What is this diverticulum? Well, it's really a remnant of the yolk stalk, or the vitelline duct. And the vitelline duct is an anchorage point of the midgut when it was attached to the yolk sac. And it can send as an ileal diverticulum, and this can ulcerate and cause problems, or it can have a fibrous cord attachment to the umbilicus, which makes it susceptible to volvulus, or it can actually have a fistula in which you may have fecal content leaking from the umbilicus in an early and young child. There can be cysts, which will produce fluids and become problematic. Also the volvulus that will become necrotic, and or a simple cord that will be vascularized. A different sort of bowel problem comes with the innervation of the bowel, which can lead to congenital Hirschsprung's disease or congenital megacolon. This is also known as aganglionic disease, or it means no peristalsis. What really happens is that the neural crest cells will fail to migrate into the hindgut's distal portions, and there won't be a myenteric or Auerbach's plexus to coordinate and control the contraction of peristaltic movements through the very distal portions of the bowel. It always affects the rectal regions, and it can be more proximal than that as well. Oftentimes it's not known why this happens. It's thought that it may be autosomal, because there is some familial inheritance, but this is not clear at this point. Males get it more commonly than females, and it can be acquired via idiopathic or toxic effects. Some of the antipsychotic medications, or even Chagas disease, one of the protozoan infections, can result in adult onsets. It's accompanied by bloating and abdominal pain and very hard stools. In an infant, it will trigger an explosive release during a rectal exam. Since the rectum is very narrow and tight because of the aganglionic nature of it, once the finger is inserted into the rectum for examination, the feces that's accumulated and dilated that more proximal portion of the bowel will then release it, and it will allow an explosive release. So it's my advice that if you suspect Hirschsprung's disease and you need to do a rectal exam on an infant, stand to the side. That concludes our portion on the viscera of the abdomen. In the next segment, we'll discuss the abdominal vessels.